Hello, I'm Allie Hines. I'm the Senior Manager of Communications for Providence Healthcare in Spokane, Washington. Thank you, everyone, for joining us today. We have a very exciting interviewee today. It's Dr. George Diaz. He is one of the top infectious disease doctors in the country and also cared for the first recorded COVID patient in the United States. So we are in good hands today. We do have to let you know that this video is for informational purposes only, and it's not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider, and with any of your questions you may have regarding a medical question. So with that, we have Dr. Diaz here with us. Thank you, Dr. Diaz, for taking time out of today to speak with us. Just to start us off, can you let us know about your role with Providence?
Sure. So I'm an infectious disease doctor. I work in Everett on the clinical service here. I also am the section chief for the department and also medical director for antibiotic stewardship. For the health system, I serve as a system provider informatist. So I primarily work on translating infectious disease content into our EMR in Epic. And lastly, I'm a principal investigator for a number of research projects regarding COVID.
And you've probably been one of the most busiest people since January 20th, which is what brings us here today. We had the first recorded patient with COVID in the United States come to our hospital, Providence Regional Medical Center, Everett, on January 20th. 8 months ago, what has in a nutshell, because it's been a while, but what has your team's biggest finding been since that day?
Yeah, so we did see the very first patient with COVID, and at that time we treated him and he got sick, and we started him on treatment with an antiviral called Remdesivir, and we saw a good result with that first patient who had developed pneumonia. And shortly thereafter, we began enrolling patients in clinical trials with Remdesivir, not just in Everett, but across our health system at a number of sites, including Swedish, Prof. Portland, and Hoag, and many other sites. And we published the results of a simple trial for treatment of Remdesivir, either 5 or 10 days of therapy, and we found that 5 days of therapy with Remdesivir appears to be equivalent to 10 days of therapy with respect to clinical improvement with patients with COVID pneumonia. And so we enrolled a lot of patients in that trial, and myself and Dr. Goldman were involved in generating that manuscript for New England Journal of Medicine. It's subsequently gotten approved or emergency use authorization with the FDA, and is essentially now one of the standards of care for treatment of COVID. Since then, we've also begun looking at the use of Remdesivir within our health system and comparing it to standard of care and hydroxychloroquine, and we found that there is a mortality benefit as well, and we're now working on getting that manuscript published as well. So we're fairly confident that Remdesivir does have a positive impact in the care of patients who have COVID pneumonia.
And there was there's changes in how Remdesivir was accessed. It's now going through the state Department of Health, correct? Has there been any issue with that new pathway?
It sort of depends where you're asking. So you're right. So Gilead, the manufacturer of Remdesivir, had donated, I think maybe about 1 million doses of Remdesivir to the federal government, and we were using that across our health system to treat these patients. And over the last about a month or so, Remdesivir has been available for purchase in the U.S. And given the concerns about the supply chain, the allocation of Remdesivir has been provided to each state Department of Health. And so the Department of Health would would receive a notification about how much remdesivir was allocated to the state, and the state would then begin working with local hospitals to determine if which hospitals would get how many vials of remdesivir. It depends on what state you live in. Some states have had more issues with obtaining remdesivir than others. For example, California, I think, was struggling with receiving enough remdesivir allocation, whereas in Washington State, I think we've generally done relatively well in that regard. More recently, Gilead has given license for use remdesivir to Pfizer, which is another large pharmaceutical company. So there's now two companies making remdesivir in the U.S. For sale. And over the last couple of weeks, we've found that the number of doses available remdesivir, at least in our state, has exceeded the need. And so the state of Washington has rerouted doses outside the state for other states to be able to use. So we think that the supply of the drug at this moment in time appears to be more than adequate to treat patients with COVID. Over time, we're not sure how many more cases we'll see in the fall as winter approaches. But for right now, it appears that we have a good supply of remdesivir across our health system. We're working very closely with each Department of Health, and so, for example, within the state of Washington, each one of our Providence ministries is engaged with the Department of Health and System Pharmacy to make sure that we are purchasing remdesivir in a uniform fashion, make sure we're using it in a uniform fashion, and that if there are depletions in supply, that we are carrying remdesivir within our state so that we can all benefit from treating our patients in a uniform fashion without one industry having access to it and another one not, for example.
So what about the other kinds of drugs or medical therapies?
Yeah, so besides remdesivir, the other sort of major, I'd say, breakthrough in the treatment of COVID has been the use of dexamethasone. There was a large study that was done in England across their country looking at the use of dexamethasone for people with COVID pneumonia, and they found that there was a benefit in patients with pneumonia requiring oxygen, and the group that seemed to benefit the most were those people that were on the ventilator. Those people that had COVID but that were not on oxygen had actually a trend to do worse. And so one of the main requirements for receiving steroids for COVID is that the patient be at least receiving oxygen. So now essentially the standard of care in the United States for COVID pneumonia is a combination of remdesivir and dexamethasone, and that's basically our standard treatment now. Anecdotally, we have seen improvements in our mortality rates over the last couple of months, so we think this has been a large advance so far. There's still certainly a lot more work to be done. We're engaged in a number of other clinical trials.
Big question is, what is the status of finding a vaccine? We've been hearing it was going to be at the beginning of hopefully of 2021. What are you hearing?
Yeah, there's a number of products that are now entering phase 3 at this point in the U.S. around the world. There have been some countries that are already vaccinating patients. The World Health Organization hasn't approved any one vaccine for a wide distribution, but there are some countries that have already begun vaccinating their population. Within the U.S., we're very hopeful. We've seen some good results in the early studies coming out of clinical trials in the U.S., where we are seeing these vaccines generate good neutralizing antibody. Realistically, time to approval is going to be early 2021, and then we'll need to manage supply chain like we have with therapeutics. So I suspect that there will be some sort of cascading vaccine according to risk to the patients, or perhaps caregivers will be prioritized, essential workers, etc. So we still anticipate that once we have a vaccine available, that the production of the vaccine and being able to vaccinate our entire population will still take some time.
Can you talk about, because whenever there's the question that comes up with the vaccine is if we could just achieve herd immunity. Do you think, can you speak to that, I guess?
Yeah, unfortunately, I think it's a really bad idea to try to achieve herd immunity. So in order to do that, you have to have at least 70 and more than 90% of your population be positive for COVID. So what we know, for example, in our area in Snohomish County, where Providence Everette is that our seropositivity is in a range of about 2% for the county, meaning that of people that we test, about 2% have had exposure to the virus and developed antibodies. That 2% exposure and infection rate has resulted in the first wave where we were really we weren't overrun, but we certainly had plenty of patients coming into the hospital. At one point, I think we had over 100 patients in our hospital that either had COVID or were being ruled out. And as you can imagine, that is a large strain on our hospital and the health system in terms of hospital beds, treatments, PPE, etc. And thankfully, we were able to manage that reasonably well, but we were strained. And that was just with a 2% sort of exposure rate in our county. So in order to get a herd immunity among 70, 90% of the population, there's no way we can house a number of patients in the hospital with that volume of people coming in. We're talking potentially, a 50-fold or 40-fold increase in the number of patients we're seeing. And that simply would not be feasible, and our hospital would be overrun with patients, and we wouldn't be able to manage that. So I think that continuing to do the things that we're doing in the state and nationally with social distancing, wearing masks, following public health directives in terms of reopening, those things are allowing us to maintain infection rates at a level that are relatively steady, at least in the state of Washington. Within my hospital, we've maintained inpatient numbers of about 20 hospitalized patients any given day, and maybe half dozen or so patients in the ICU. And this is with the county relatively well adhering to the public health mandates for distancing and mask wearing, et cetera. So thankfully, in our area, that's been our experience. And our population is continue to do those in order to not be overrun.
Yeah. Thank you for addressing that. I know that's a question that has come up often in our service area. We have a question from Facebook for you. Do you have any information about how people can sign up to be part of vaccine trials?
Yeah, so if you go to clinicaltrials.gov, that will give you, and you type in COVID vaccine, you should be able to see what sites are enrolling in vaccine trials right now. There are some in Washington State with our health system. I know we're looking at 3 or 4 vaccine candidates. I don't think we've opened any trials yet within our health system, but we should hopefully be doing so relatively soon. And once we have access to a vaccine trial, we will probably publish that so that our caregivers and our patients can begin enrolling in those trials.
Let's go back to talking about caring for these patients. We talked about the therapy, Remdesivir and the other kind of therapies that we have. But something that's come out of this is the technologies. Can you talk about how you cared for these patients using these new technologies? Because there was quite a few of them.
Yeah, and actually that's a really good point. So one of the things that we did early on is we knew that we were going to see a lot of patients coming into our EDs and other care settings with symptoms of COVID. And we knew that we probably didn't have enough beds to take care of people that didn't need to be in the hospital. And so within our health system, we began working on algorithms to be able to triage people to either admission or home. And one of the areas that we were really concerned about were people that had COVID or possibly had COVID and were high risk for complications, people above the age of 70 or diabetes, obesity, hypertension, et cetera, where we felt that there was a higher risk for these patients decompensating, despite perhaps looking okay in the ER. And so we developed a telehealth home monitoring program where we if a patient looked like they were clinically stable in an ED visit or urgent care visit, their oxygen levels were good, they felt okay, they weren't dehydrated, they looked like they could go home, but they still had risk factors that were concerning for us, we would provide them with an oximeter, another thermometer, and plug them into our Providence telehealth program. And those patients would then go home and they would contact telehealth either using Zoom or simply by phone if they didn't have access to like a smartphone or a tablet or something. And an ICU nurse, centrally based, would contact them, would check on them a couple times a day and record their vital signs and do symptom screening to see how they're doing. And this program really allowed us to safely care for patients with COVID disease outside the hospital in a safe manner. And also allowed us to bring them back quickly if they did get worse and need admission. And so we're in the middle of now working to examine this population of patients to really show more definitively that this care model works. And we're collaborating with the group, the core research group in Portland, to look at this care experience. We think it was extremely positive in terms of both patient satisfaction and safety. And so we want to prove that by publishing the results.
So home monitoring for the ones that could go home. What about the patients that needed to stay in the hospital? What kind of technologies did we utilize there?
Yeah, so with our first patient, we used a telehealth robot to monitor him in the hospital. Once we started seeing larger numbers where using that sort of technology wasn't really feasible, we began doing remote visits even in the hospital. So an example would be just calling the patient by phone outside the room and chatting with them through the room so that we could do history physicals and conserve PPE and reduce exposures. And those simple things, I think, helped. The other thing that we did as well that I think also helped with length of stay was if a patient improved, we could also discharge them to home on telehealth as well. So we could try to discharge them early on telehealth monitoring so that we could get them out of the hospital safely and open up a bed for their patients, as well as try to reduce exposures for our caregivers also.
Before we switch gears to talk about testing, I just want to put a plug that if anybody has questions for Dr. Diaz, please post them on Facebook, post them on LinkedIn, and we'll be sure to get them answered. But for now, let's talk about testing. How are we managing that so far?
Yeah, so testing, has been, I'd say, an issue from the get-go. Even from the start of the pandemic, we had a lot of issues with being able to get results rapidly, and that improved over the second few months of the pandemic. As the pandemic has moved to larger urban centers in the East Coast as well as the Southwest, we had been seeing longer turnaround times for outpatient testing. Thankfully, we've done pretty well on inpatient testing so that our turnaround times have been relatively good. Our health system has been working very hard to secure supply chain for testing kits, reagents, swabs, etc. And so thankfully, we haven't had as big a problem on the inpatient side. On the outpatient side, the Providence Health System has stood up a lot of different testing sites, drive-through testing, etc. We've been very successful to get patients tested. In the state of Washington, the turnaround times appear at this point to be about 24 to 48 hours. So it's definitely improved over the last few weeks as the larger commercial labs in the country have ramped up their supply chain as well. So at the moment, I think we're doing relatively well. We're being very careful with testing. We do have a lot of reporting requirements to the federal government when we test people. So we have to indicate if the patients are symptomatic or not, what the risk factors are, and other things about to making sure that we're testing people appropriately, and so we can report our testing results and get a national database for how patients are tested in what order, etc.
Do you foresee a second wave, or has the data begun to indicate that something different?
we sort of anticipate a second wave because right now in the summertime, most people have access to being outside, and it's a little bit easier to socially distance when the weather's good. And so as the weather gets colder in the fall, we would expect, like any other respiratory virus, that also peaks in the winter months, that we would likely see an increase in COVID in the fall as well. We are certainly preparing that with our health system, as well as collaborating with national groups, including Infectious Society of America and CDC, to make sure that we have a good plan for a second wave in the fall, which is, I think we probably are expecting at this point.
And obviously flu season's coming up. So, how do you anticipate that could affect hospital capacity?
You're absolutely right. In any given year, flu seasons actually make us get near our capacity in our hospitals due to people coming in with influenza. We do, I think, a good job of vaccinating our caregivers, and we really shoot for being well over 90% vaccination rates for our caregivers. Influenza and COVID can be quite similar in presentation and very difficult to distinguish just clinically, and so we sort of anticipate also seeing people coming in with influenza in the hospital. It makes it even more important at this point that we try to get our population vaccinated for influenza. And at least, at my hospital, we're working on potentially vaccinating people through our ER and really focusing on a strong vaccine push this year for influenza to try to really reduce the number of cases we see in the hospital that will compete with COVID cases as well.
Yeah.
So influenza vaccination this year is extremely important.
We have a question from Facebook. How worried are you about the fall when there is usually, that's it. Okay, we already answered this one. Do you feel COVID will be more of a concern as well as we all spend more time inside? So yes, you just answered that. Sorry, should have read that before. So has any of the research involved in the treatment has any of your research been involved in the treatment of post-viral syndrome?
No, we do see quite a few syndromes, and nearly any organ in the human body can be affected by COVID. We are looking a little bit at that, but there are different centers that are collecting large data on complications of COVID. That has not been a focus of our research, but it is an active field, and we've found numerous cases of complications from COVID after the infection is resolved.
So where do you see us going from here?
So we know we have Remdesivir, we have steroids at this point. Those are both positive results. We still, unfortunately, do see serious infection in patients. The areas that we're looking at are really twofold. One, how do we treat the sickest patients? And so our health system is involved in numerous clinical trials trying to reduce the effects of the immune system that play a big role in severe COVID pneumonia. And so we have clinical trials that are blocking certain parts of the immune system to try to reduce inflammation in the lung. There's a wide variety of different therapies that are being tested, and importantly, these are all therapeutics are being tested in a randomized controlled trials, so that we will definitively be able to answer whether or not they're helpful. So that's sort of the first phase of the sicker patients. I think we're doing much better with patients that are ill but not in the IC, for example. The other area that we're starting to focus on is in the outpatient treatment of people with COVID. And so there's several trials that we're looking at now that we're enrolling in as well. One is a trial looking at the use of monoclonal antibodies. So, for example, COVID, the virus itself has these spikes on the end of it. So here's a little doll of COVID. So these are little spikes. So we have these monoclonal antibodies that will bind these spikes. So those are called anti-spike antibodies. And we have these antibody cocktails that we're using to infuse patients with. And the idea is basically to try to prevent people that have COVID from getting sick by using these antibodies. We would also use them in people recently diagnosed that don't have much in the way of symptoms, and also treat people that have household contacts that are positive for COVID. So we know that the greatest risk of infection is having someone in your home have COVID. And so by trying to prevent transmission of disease in the household, I think is an important area that we're looking at right now. And so those trials are just now kicking off. And we're just starting to enroll patients like right now. And so that will be something that we're working on quite a bit here. The other treatment that we're looking at is the outpatient treatment of patients with COVID with Remdesivir. So one particular group that is very vulnerable is patients in skilled nursing facilities. We know that overall the death rates, if you live in a nursing home and you get COVID, your mortality is anywhere between 25 and 33%. And so we're going to be focusing on trying to treat those patients as early as possible. So what we'll be doing is once they're positive, we'll bring them into the hospital for an outpatient infusion of Remdesivir, and then send them back with Remdesivir to receive at the nursing home. And the idea there is to try to prevent them from getting sick and coming to the hospital and hopefully preventing death. So those are those trials. We're also looking at inhaled Remdesivir. So these were phase 1 studies where we're looking at whether or not an inhalation of Remdesivir, like through like a nebulizer, can also prevent disease, which would eliminate the need for having to do this through an IV treatment. So we're focusing right now mostly on the sickest patients with immune modulators and outpatients with either antibody infusions or outpatient treatment with Remdesivir. We're hopeful that these will be successful and add to our armamentarium against COVID.
We have time for about one more question, and we did get one from Facebook that's on the same topic as the flu. When is the best time to get the flu shot? September, October? When would you suggest?
I would say the best time is to get it as soon as you can, because we still have quite a bit of COVID circulating right now in the community. And if you can prevent yourself from getting influenza, that will prevent you from having to go to the hospital and being in the ER and being worked up for COVID, since we won't be easily able to tell the difference between flu and COVID. So as soon as the vaccine is available, I encourage you to get vaccinated. The vaccine should help you develop immunity throughout the entire flu season.
Is there anything else that you wanted to add today, Dr. Diaz?
No, I think that the last thing I want to mention is that our health system is working on a large seroprevalence study looking at the prevalence of antibodies or caregivers. We're enrolling numerous sites now within our health system, and so Sacred Heart will be going up live at the end of the month. Walla Walla is already going now, and many other centers within our health system are going to be participating, and we're going to try to identify if there's additional risks for our caregivers to develop antibodies that we can mitigate by changing practice or PPE or whatever. So we're excited about that large study as well.
Can you speak to that a little bit? I know that we've had results from at least one of our service areas, correct?
Yeah, so we did a pilot in Everett we screened 2,500 patients. We had a seropositivity of 2.3%. We didn't see any major spikes with caregivers, except for those that had positive people in their household that had disease. So again, indicating to us it's really the biggest mode of transmission for people with COVID is in the household. And so those are very preliminary results. We're accruing many more patients, and we'll hopefully have a lot more information to share over the next few months.
Perfect. Thank you so much for your time today, Dr. Diaz, and thank you all for joining us. For everyone listening and sending in your questions. To learn more about our initiatives, you can visit our website, providence.org, and make sure to follow us on social media. Just search Providence Health System on LinkedIn and Facebook and Instagram, and just under Providence on Twitter. Thanks and have a great day.
Thank you.